Hi there, everybody. It's Professor Jason Goodwin, and I'm here to talk to you about pharmacology today. We're going to do a lot of good work studying pharmacology, a lot of comedy, and sneak in a little bit of teaching in there. So here we go. All right, so we're going to talk about student learning outcomes first. We're going to put an emphasis on the adult and older adult clients. So the student will learn how drugs are named and classified, the mechanisms that promote quality, drug, and safety, and systems for storing and distributing medications. Number 2, we're going to discuss medication pharmacokinetics. We're going to go through absorption, including advantages and disadvantages of common routes, distribution, metabolism, and excretion, onset, peak, and duration, therapeutic range, biological half-life, and target site concentration, and other factors that affect pharmacokinetics. How's that sound? Well, let's do some more. We're also going to discuss medication pharmacodynamics, primary and secondary effects, medication interactions, drug abuse and misuse, and describe measuring doses by metric system, units, and milliequivalents, and explaining types of prescriptions. We're not going to use abbreviations or communicating prescriptions and what to do if a prescription is incorrect for the RN. Further, we're going to describe why medication errors occur, how to avoid limitations of technology, and what to do if an error occurs. We're going to talk a little bit about human factors of error in that, and we're going to apply the nursing process to medication administration. All while explaining the importance of teaching clients about medication self-administration. So we're going to do it, we're going to teach it, we're going to describe and demonstrate in three checks and the 6 rights required to safely administer medications, especially older adults. We'll add one more in there just for good measure. And finally, we're going to describe and demonstrate in lab medication administration by oral, buccal, and sublingual, topical, ophthalmic, otic, nasal, vaginal, rectal routes, other special situations, children, respiratory inhalations, and we did not say yet IV. So everything but IV. Oh, I guess they snuck one more in. And describe and demonstrate lab medication administration by subcutaneous and IM routes. So we're going to look at needles, syringes, gauges, sizes, drawing up medications in ampules versus vials, accounting for needle dead space, mixing syringes or mixing medications in syringes, how we prevent needle stick injuries, common safety considerations that are accepted around needle safety, choosing sites that are appropriate for subcutaneous administration and administering heparin, and also choosing IM sites with the Z-track technique. And if it weren't more, we have discussing considerations for older adults regarding medication issues, changes in physiology and pharmacokinetics, and problematic medications. We'll explain cultural considerations in all of this, and we'll use current edition of Davis's Drug Guide for Nurses in order to do that. This is a course that's intended for first semester nursing students, and so we'll get into that right away. Okay, so what is pharmacology? I think you probably know this by now, but somewhere along the line somebody gave it to you. It's any chemical that affects the physiologic process of a living organism. So, it's also called the study of and science of drugs. That's pharmacology. Very exciting. A lot to learn about it. Very intimidating for some people. We don't need to make it that way. So we're going to talk about drug names. So I'm going to move myself here so I don't get in the way of you guys so you can see what's important. Okay, so drug names. So drugs will acquire at least 3 different names. And so they'll have their chemical name, their generic name, and their trade name. And so we'll get into that a little bit more in depth because it's important for you to understand all 3, and definitely use 2 instead of just 1 because some of them are names that you might hear on commercials, but others that are names you might not hear as much, their generic name, but can also be give you hints towards their pharmaceutical class. So we'll talk about that. Patent life is about 17 years. The research process takes about 10 years. So a drug manufacturer usually can get a drug out of research and development in the 10-year stage if they're lucky. And so they have about 7 years to where it's patented, nobody else can touch it. And then at the end of that 7 years, they have to allow other people to make the drug, right? So that's sort of the lifespan of a pharmaceutical product. So there are examples of chemical and brand names. So Motrin's here on the bottom. So I'm gonna move myself here. Okay, so on our left-hand side we have what you may know as Prozac, right? It's on the right-hand side brand name, and that's fluoxetine. And then you have your chemical name in the middle. It's not always necessary to memorize the chemical name, but that will tell you exactly what the chemical process is, so that if you want to go into the organic chemistry or anything like that, that's exactly what it is. You have acetaminophen on the left-hand side, as well as Tylenol on the right. We probably know that one. And then when somebody asks you if you can take some Motrin and you say, no, take ibuprofen, right? That's the same thing. So we have our Prozac, which later on we'll learn is a SSRI, a selective serotonin reuptake inhibitor. You have Tylenol, which is a pain reliever, non-narcotic, non-opioid. And then you have your anti-inflammatory, non-steroidal anti-inflammatory med, right? Which is Motrin. So we'll keep going on that, and we'll hit that a lot. So looking at drug classifications. So you have to be able to look these drugs up, okay? There's nobody in medicine in any country, anywhere in the world, that has memorized everything. And if they have, the next day they're behind again, right? So this is a labor of love. You have to understand that you're always going to be looking drugs up. Sometimes it's helpful for us to have a handy tool to carry with us, because in any unit, usually you're handling between 25 and 30 drugs maximum, most commonly. So to have that reference information is extremely helpful, so that you don't have to search it out every time. But that being said, there's always going to be things that come in that you don't know what it does. So you want to understand by usage, why is a drug used, where it works, the body system, and what chemical or pharmacological class it's in. So sometimes drugs are put into more than one class, okay? So a good example of that could be, let's use Motrin. It's an analgesic, okay? And so that would be the class by usage. But it's also an anti-inflammatory and an antipyretic, right? And so what happens is oftentimes you will hear it called something, and like for instance, a good example of that, and we'll go into this in a little bit, is there's a lot of drugs that are antihypertensive, right? They help with hypertension. But within that class, that description, there's several different pharmaceutical classes within that. So you have your beta blockers and your ACE inhibitors, etc., right? And so there may be more than one class, and then there's almost like a subclass in some cases that you'll describe. Sometimes those subclasses tell you a lot more about what the actual mechanism of the drug is. So we use the Davis's Drug Guide, and they list approximately 50 different classifications of drugs. But if you use one online, I'm sure you probably find one with more. But it's always great to have a useful companion. And a lot of the electronic health records these days actually have some of those things built into them as well. And of course, you can always work with your pharmacist, who is also a trusted colleague as well. Okay, so mechanisms to promote quality and safety. We talked about, if you're in doubt, look it up, okay? We'll say that again just so that you hear it. But there's lots of different ways to look things up. There's what's called a pharmacopoeia, and that's sort of like the pharmacist's Bible, right? It has everything in the national formulary that's ever been made, tells you all about it. You have your nursing drug handbooks, which I'm sure you've seen. You have your what's called the PDR, your physician's desk reference. Any kind of pharmacology texts, electronic and internet-based formularies, things like Micromedics or tons of other, even WebMD, although that's focused mostly on patient information. And then, of course, you can check your package insert whenever you get your medications. And then there's always the institutional medication policies and procedures. All of those are important to check yourself to make sure that you're practicing safely if you have a question. Okay, so we don't, storage and supply of medications is in a hospital. That's not just something that comes out of your kitchen. That's pretty serious, right? And we take it seriously. So we have systems to make sure that we're not keeping it in a way that could be dangerous. So here's what we do. You have specific areas, if you haven't seen them already, at your clinical site where you're designated for preparing or storing medications. And so one of the things that you'll see is a stock supply. So that's a medication that's used most frequently in a shelf, or it's supplied in bulk quantity, okay, and it's in a central location. So for instance, a good example of that would be, perhaps if your unit has some IV fluids, right, that are stored. So you would have to go to a central location to get that. And then you have a unit dose system. So this is where it's more individually dosed based on the patient needs. And so an example of that would be someone, it's a system of coordinated by the pharmacy. So everything's supplied in a single use package, right? And so you might go in and you might see it in there, like maybe you have a certain type of like chlorhexidine wash or swish and swirl, right? Which is an ordered medication, right? Just because we're using it to swish in our mouth doesn't mean we just give it to someone without an order. But that would be a unit order because it's just one dose, okay? And so that's supplied as well. Usually it's delivered about every 24 hours. And an example of that, if you've used the Pyxis, those are all unit doses in there, right? And so those are individually supplied. Depending on where you are, it would either be attached to the patient before you go there, or it would be like in an operating room, for instance, it would be not attached to a patient until you give it. But for those of us that have used an automated dispensing system like Pyxis, that's what you would do is you'd go up, you'd scan your patient, and you would be able to remove the medication. There's a verification process there to check that it's the right medication, and you're involved in that too. Of course, we always do our processes regardless of the technology backing it up, right? That's a positive redundancy. We want that redundant process for quality. So then we get that from the Pyxis, and then there's even an example of self-administration. And so the easiest way to talk about that would be if you've ever been at the hospital and one of your family members has what they might call a pain pump, right? Where they're post-operative and they have a lot of pain and they have a narcotic, they call it a patient-controlled analgesia machine. So that would be a PCA, right? So that's one where they have the button, and every once in a while you teach them when you first give it to them, hey, if you have pain that's greater than 6 or whatever the parameters are, push this button. You can push it once every 6 minutes, and it'll give you more. If you press it more than that, it won't give you more. Just kind of take them through the whole process of that. So here's what a Pyxis looks like, and there's lots of different. There's more than one brand of these types of machines, but this is what a Pyxis looks like. And so you go up to the screen there, you scan it, some of the meds pop out from the middle there, or even on the right, there's some more stock supplies. You could see some fluids and things like that in there as well. Okay, so we're going to talk about pharmacokinetics. All right, there's a little bit of a mnemonic there, ADME, right? And so there are 4 processes that determine the intensity and duration of a drug's actions, ADME. So absorption. How are you absorbing the drug? Is it easily absorbed? Is there something getting in the way of the absorption? How is it administered, and how's that working, right? Then you have distribution. Is it able to get where it's going to, right? You absorbed it, but is it going to be carried there? Then you have a metabolism. So you absorbed it, it's getting carried. Was it actually metabolized in a way that can deliver the chemical that's needed to create the situation. And then excretion. How are we getting rid of it? Is it easily gotten rid of? Are there costs of it from an organ perspective? And so how does that all work? So we talked about this before. Absorption refers to the movement of the drug from the site of administration into the bloodstream. Okay. So bioavailability is a subcategory of absorption. And so it talks about the proportion of the drug that enters the circulation and is able to have an effect. And so we'll come back to this in a few minutes, but that's what we're looking at right there. So you have your, when you give that, you have your route of administration. The form of the drug is important also, and that plays into it. The solubility of the drug, and we'll talk about that, and that plays into your metabolism and how it's available. The effects of the pH. So depending on what your pH is in the body and the area you gave it, and the drug itself, if there's some sort of an ideal state and your one or the other is off, then that can affect the ultimate absorption of it, right? And then what's the blood flow to the area? Because if it's not carrying blood readily, then it's not going to be absorbed, it's not going to be distributed. So all of that plays into it. And also body surface area. So sometimes, like you've probably seen that when we inject something, we have certain sites we choose. And a lot of those have to do with the fact that there's a lot of flesh in the area, because we want a lot of body surface area so that there's a ready chance for absorption as widely as possible so that it can be distributed. Okay, so route of administration. So drugs are manufactured for a specific route. Okay, enteral, parenteral, or topical. That means oral, IV, or topical on top of the skin. So enteral involves absorption through the GI tract. Okay, so that would be either through your mouth, through your stomach, and even through a feeding tube, and even rectal administration. Okay, so all of those refer to that route. Parenteral is more of like parenteral is a non-oral means, and so what that would do is that would be related to anything that's injected into the body, and that bypasses the skin and mucous membranes, and also may bypass the GI tract completely, right? So that's something that changes the way that the drugs are manufactured and the dosages and things like that. Oral medications often have a much higher dose than the IV forms of the drug, so they're not the same drug. Drugs are given either locally or for systemic effect. So the local effects occur at the site of application. Great point of that is like lidocaine. Okay, you put that into the site. It's not like injecting lidocaine into an artery, right? You're going to have a very different response. And then you have your systemic effects. And so if you inject lidocaine into a small amount on top of an IV, and you put what may be referred to as a wheal over the vein, you're protecting someone from pain when you inject the vein. If you inject that larger amount into a vein or into an artery, a central area of the body, that will have more of a systemic effect, and that will take that harmless amide anesthetic, that numbing medication, and turn it into a potentially cardiac excitatory situation and cause problems, right? So your choice of route is critical, and so you just have to be aware of that. And one of the things that is sort of the point that we want to make about it is that when you have a situation where a patient is vomiting, that's not a situation where you're going to want to administer oral medications if they're critical, right? So just keep that in mind. Okay, so blood flow to the area. So medications are absorbed based on how the blood flow is to the area. So for instance, if you give sublingual nitroglycerin for some sort of a heart problem, and you put it underneath the tongue, that's a very vascular area, and so you're going to get a lot of great absorption there. Areas with poor vascular supply, for instance, topical creams, or areas that have some sort of a disruption in the skin, maybe scarring, that's all going to be problematic for the absorption. So it's important you understand that. Makes sense, right? But that's one of the things that is important to know. Then you talk about absorption. We've talked about distribution. So here are your routes. This is a nice little graphic that you can use. With your distribution, it has a lot to do with the capability of the capillary membrane and how that plasma and other whatever else we use to carry the products can carry it throughout the vasculature. So plasma, blood, lymphatics, things like that. And then we have our metabolism, which is mostly done in the liver. And so then we have excretion. And so the liver can excrete, the kidneys can excrete, the lungs, and the skin. So we can excrete by all of those areas. How are drugs distributed throughout the body? Well, usually in the bloodstream, and it travels to various tissues and different organs in the body. The influence of this depends mostly on the local blood flow in the target area, what the capillaries are like compared to the drug molecules, so the permeability of the membranes, the size of the molecules, and then the protein binding capacity of the drug, and we're going to get into that. So protein binding can affect a drug's ability to perform, and so in general, drugs that are minimally protein bound, so a smaller amount of them that are bound, are usually better at penetrating tissue than those that are highly bound. But they are excreted much faster. So we'll go into some of this. So only free or unbound drugs interact with receptors. Okay, so when things are bound, that means that the protein has sort of has assumed power on it, right? And doesn't allow it to freely go out and interact with other receptors. Excuse me. So we'll go into this a little bit further. So as an example, warfarin or Coumadin is 99% protein bound. So only 1% is free to get distributed, metabolized, and excreted. It probably makes a little bit more sense once you describe it, right? So on the other hand, like for instance, if there's a drug that's given shortly thereafter, drug B is administered and both are protein bound, drug B can displace drug A from the protein. So here's and increase the drug A's free percentage. So essentially what happens is, so if you have a drug that was that like you give a drug like warfarin and it's bound to a protein, right? And then you have a different drug you give after that. Sometimes what happens is it can sort of take over, right? And so because of that, it creates A's free percentage. That A can actually be potentiated, right? So that's what we talk about when we say potentiation. The actual drug can lead to a toxicity. So just understand that when you give other drugs that they can interact, that's part of what we usually call it an interaction, right? Or a contraindication. But what's essentially happening is on a cellular level, these medications are taking up space over one another, which can sometimes lead to a change in the way that chemistry is happening. Okay, so metabolism. How do we metabolize drugs? It's also called biotransformation. So what we do is when we metabolize something, we chemically inactivate it. And so it converts it into more of like a water-soluble compound or metabolites that the body can use and excrete. Most of this happens in the liver, which is also why if you have some sort of a liver impairment, we're always thinking, usually it's like we think liver and kidneys, right? Is there anything going on? But liver in particular, the drug will be eliminated slower or maybe even not at all. And so that can create damage to the liver or create toxic levels that can accumulate. So we want to be careful about this. One of the concepts about this is called the first pass effect. So meds are absorbed in the GI tract and then they circulate through the liver before they reach the systemic circulation, right? So And so that's, as I said before, that's the reason why oral meds are formulated with a higher concentration than parenteral meds. Because what happens is those meds are absorbed from the GI tract, and then they circulate in the liver, and then they reach circulation. And then, so the parenteral meds, they go directly to that, right? And so you need a greater amount to affect the effect that you're trying to treat. So how are drugs excreted from the body? Well, they can be metabolized completely, partially, or not at all when excreted. So our common organs, as we said, kidneys, liver, GI tract, lungs, and exocrine glands. The major routes of excretion are through the renal and the biliary excretion. Okay, so that means your lungs and your kidneys. Other things, as we've talked about before, your pulmonary excretion, so you breathe it out. Your salivary excretion, so you can get rid of it in your spit. Your mammary, via milk if you're a breastfeeding female. And then skin and dermal excretion via sweat. So it's probably not a surprising thing to you to learn that, but that's what you can see. So let's talk about a question. Which factor in a patient's medical history is most likely to prolong the half-life of certain drugs? So we have A, heart disease, 1, heart disease, 2, liver disease, 3, rheumatoid arthritis, and 4, tobacco use. Well, let's try to eliminate some. So I'm not sure what tobacco use would alter in a half-life of any drug, so just personally I'm going to eliminate that. Then we have rheumatoid arthritis, which we if you look it up, you'll learn that it's a autoimmune disease, so it's attacking its own immune system, which shouldn't really have anything to do with the half-life of drugs. So then that leaves me with the heart and the liver. So what does the heart do? The heart's a blood pump. The heart is not in the business of metabolizing drugs, right? So only the liver is in this group. So that's what we're going to choose, is the liver. Okay, let's go through onset, peak, and duration of drug action. This is stuff you use all your career, and it's really interesting. So the onset is the time needed for a drug concentration to reach a high enough level for its effects to appear. Okay, note that it says the high enough concentration for its effects to appear. That doesn't mean it's not present, right? But the time needed for the onset. So it's also called a minimum effective concentration. So what we usually say when we refer to onset is an amount of time. So 2 to 5 minutes is what it takes for, morphine to take effect or something like that, right? And then the peak action is when the concentration of medication is at its highest. We refer to that as a peak. And so typically, let's say the onset for fentanyl is 1 minute to 5 minutes. And then its peak action is at 7 to 10, right? And then the duration of action might be up to 30 minutes. So that's a period of time where there's an effect on the medication. What's important about the duration is that's usually when you can assume that the drug is now a little bit more on the safe side to not to have to monitor as closely. Now, that's an easy statement to say as a blanket. I'm not trying to be that simple with it. But as an example for narcotics, if you have reached the duration of the narcotic that you're using, the patient is not in pain, and the patient doesn't have any other physiologic concern, or is ready to go home, then that's probably a good indication that that's appropriate at that time, right? So duration is important for helping us determine that. All right, so here's an example of how all these things apply to insulin, okay? So if you've done any time in the hospital, or maybe run across this at home or something like that, you notice that some people that are on diabetic medications are on different ones. So we have your different types of diabetic medications. The really fast ones, right? Lispro is one of the most common ones you'll see used. And that is very quickly acting, and the insulin peak comes very fast, right? And then it also leaves quickly. So, you're talking about within 4.5 hours, it's completely gone. And the peak is, 1.5 to 2. And then you have your regular insulin that has a little bit longer of a peak, and the total duration will be from 0 to 7. Does that make sense? Okay. So then here we have the NPH, which is a long-acting, and so what you see is the onset, and so the onset for these are both very quick, right? Onset for NPH looks like maybe it takes a little longer. As you can see that, maybe that's 30-45 minutes. And then it starts to peak here, and then the duration looks like it's approaching 17 hours. And then the even longer ones, right, which are ongoing with a very lower peak, right? You see that? And so you'll also notice that the rapid acting ones have a very high activity peak. So that's the way different drugs can be even layered on top of each other, right? And so a lot of what you do in a procedural sedation situation is like this, and it's why you have to understand your drugs and your durations, your onsets, your peaks, and your durations. It'll keep you out of trouble. Okay, the therapeutic range is when you're giving a multi-dose medication, like let's say you're giving vancomycin, okay? So you want to achieve what is a constant therapeutic blood level, okay? So one of the reasons they give antibiotics immediately before a surgical cut is because they want that medication to be at its highest in the bloodstream at the very moment that the surgery is occurring. And so that's an example of that therapeutic level being there. And so you have to understand what the therapeutic range is for that antibiotic to make sure that it's going to provide you the best protection against any kind of pathogens. So when you're talking about that, you'll go into biologic half-life. So this is the amount of time it takes half of the drug to be eliminated, okay? So we'll use tramadol as an example, has a half-life of 6 hours. So if you take 50 milligrams at 8 o'clock, by 1400, 25 milligrams will still be left in your body, okay? And then by 12, 12 and a half will be left. So this is also, of course, affected by all the things we talked about before, including the absorption, drug composition, distribution, and any of those things, including any kind of liver or other organ disease, right? And so other things like aging, absence of food, those things will all prolong the half-life. Now, this is different than duration. Duration relates to the action of the medication, the effect. This has to do with how much has been eliminated, okay? So here's a half-life graph. The concentration of a drug, for instance, is at 100%, right? And if the half-life of the drug is 1 hour, then that's where you're going to be at 1 hour, 50%, right? And then at 2 hours, you'll be at 50% of that other drug, or the other percentage, right? Which ultimately brings you down to 25%, and then 12%, and then 6%, and so on. Does that make sense? Okay. So pharmacokinetics, what affects these things? So age affects it. If you're an infant or an older adult, those are things going to take you out of the normal curve. Body mass, if you're very large or very small, those are atypical, and most of these ideas are made for the 98% of the population. Different genders matter, especially with pregnancy and some of those types of things. Teratogenic means it's dangerous and can cause cancer potentially in babies. So anything that you give a pregnant female should be checked, verified with the drug book to make sure there's no kind of pregnancy warning or anything like that. Your environment can even affect your pharmacokinetics. Like for instance, if you're very cold or you're very hot. The timing of the administration is obviously important. That's why we time our medications and we don't give them too long before or after. The fluids, our fluid status, and where we're at matters. Our pathological states, including any chronic diseases or any genetic factors, and even psychological factors can make a difference for that. Okay, pharmacodynamics, secondary effects. So let's talk about primary therapeutic effects first. So primary or therapeutic effects are predicted, intended, and desired. Okay, and then we have palliative effects, which make a patient comfortable. So that's where you hear about palliative care, right? And so supportive effects, those maintain body functions while a patient is recovering from illness or injury. So giving a person electrolytes to prevent dehydration. And then substitutive effects, chemotherapeutic effects, and restorative effects are all different reasons why you would use pharmacodynamics. Substitutive effects, maybe you're trying to replace a functioning thyroid, right? So you would get thyroid medication. Chemotherapeutic effects, maybe you have something that is growing and you have to take a certain type of infusion to kill the cancer, right? And then restorative effects, there's lots of reasons why people might do that, but the one that comes to mind to me is maybe hormonal treatments, right, that you might get to restore certain hormone levels and certain effects that you would want later in life. Okay, secondary effects. These are unintended. So the primary effects are pretty clear, right? This is what we're trying to solve. The secondary effects are unintended, but they're often predictable, and they are physiological, okay? So the patients can usually adapt to this. A lot of times we see it as a side effect, and it is, but these are secondary effects. These are not unexpected things. So, and this could be sort of a blanket statement, nausea, vomiting, diarrhea, dizziness, drowsiness, dry mouth, abdominal distension, and constipation. Anybody ever watch those shows, the commercials that talk about the different medications? And that's what they say every time, right? And so a lot of these are sort of the similar things that almost everything causes. And then you have an adverse reaction. And so an adverse reaction is different. A side effect is something we can expect. An adverse reaction is harmful and it's unintended. And it's usually unpredictable reactions. So this should be at the normal dosage, and it can create death. And then you have severe adverse reactions, which the FDA defines as life-threatening, requiring intervention to prevent permanent impairment or death, leading to congenital abnormality, disability, hospitalization, or death, for obvious reasons. And then you have toxic reactions. So dangerous, damaging effects to an organ or a tissue. So toxicity is very much like a poison. And so an overdose, we all hear plenty about that these days with fentanyl. You hear about that happening, right? Same thing can happen with hypoglycemia from insulin. Accumulation, sometimes what happens is a drug is not eliminated well. We talked about elimination, right? If it's not eliminated well, the drug can continue to raise in the blood or in the system, and next thing you know, it accumulates and creates toxicity. Abnormal sensitivity, whether it be allergic reaction or some kind of sensitivity, that can be something that's toxic but not expected just because there's a very naive physical tolerance to it. And something that's localized. Okay, allergic reactions. So your immune system identifies this as a medication as a foreign substance that should be neutralized or destroyed. So when you have an allergic reaction, your immune system identifies it and says that doesn't belong here. Okay, and so this can go from minor to serious. Urticaria, or hives, pruritus or itching, edema of the soft tissue and mucosa, rhinitis, inflammation of the nasal mucosa. So itchy eyes, itchy nose, itchy mouth, edema of some of the mucosa, maybe even angioedema, which is around the lips, and inflammation. That's more on the minor side. And then when you get to the serious side, it's along lines on a spectrum towards anaphylaxis. So anytime that you start having more swelling around the face, any trouble whatsoever breathing, any tightness in the chest, those are all things that are life-threatening. because obviously at some point it can obstruct your ability to move air. So constriction of the bronchioles, edema of the larynx, shortness of breath or wheezing or low blood pressure, those are all signs of a very serious reaction. Everyone talks about, I had an anaphylactic reaction. Most likely they had a moderate allergic reaction that required Benadryl or something like that. An anaphylactic reaction, a true reaction, you might get Benadryl, but they're going to be looking for the epinephrine as well, because they're going to need to make sure that you're safe, right? So that's the difference. Now, the treatment, like I said, you're going to discontinue. The first thing you're going to do with any kind of allergic reaction is remove the allergen, right? So what is it? Is it a bee sting? You're going to remove the sting as quickly as possible, and make sure you get away from bees, right? And remove yourself from the situation. If it's certain types of, if it's peanuts, make sure you're not eating peanuts anymore, or you're removing yourself from that environment. And then you treat it, and often it's with epinephrine or an IV fluids to support the vascular tone. And we'll talk later when you get into sepsis and things like that sometimes there are changes, not sepsis, but the other type, which is anaphylactic shock. And there are times when it can alter your vascular ability to move fluids and perfuse correctly. And then we use steroids, corticosteroids for that as well, which decreases inflammation, and then antihistamines. And ultimately, we do potentially even intubate someone if they are having a potential problem breathing and we're not sure we're going to be able to control it. We'll put that mechanical tube in there just because we know that it's going to be secure while everything else gets managed. Okay, so we've talked a little bit about this earlier. I talked to a few of you separately. How do medications interact? So we have the antagonistic drug relationship. So that's when one drug interferes with the actions of the other, okay? And it decreases the resultant drug effect. Then we have a synergistic drug relationship. So when you take them together, they potentiate each other. And then you have a drug that's just plain incompatible. All right, so we're talking about drug abuse and misuse. So non-therapeutic use or effective drugs that are either prescribed or non-prescribed, the issue with those things is, first of all, they can be abusable, right? And almost anything can be abused, not just the drugs that are Schedule 1 or anything like that. And over time, when somebody takes drugs and they're trying to create a certain effect, that doesn't work permanently. So they may achieve that effect initially, but over time, their tolerance becomes such that the same amount of that drug does no longer create what they're hoping for. And so hence starts the cycle of dependence, right? And so you're trying to get more and more and more to give you that same, you're chasing that same thing you saw the first time. And it rarely happens that way. It's elusive from the very first time. And then at some point you continue to use it until your body is living in a state of toxicity. And while you're misusing the drug, you're at risk for overdose. You're using it other than what it was intended for. And a lot of these drugs are highly addictive. And so you end up down a road of either feeling like you are dependent on it or dying from overdose or jail. So it's a really unfortunate situation for people to struggle with. Okay, so when we measure doses, we're using the metric system. All right, so there's if you don't know the metric system by now, you will, because we use it in medicine all the time. And so it's the preferred system we use. And it promotes accuracy because it is very sensitive, and so it allows for very small drug dosages. So that's a positive. So starting with units. Insulin, most drugs are measured in milliliters, milligrams, and we'll go along with this and you'll see insulin is always measured in units. Okay, there's something called an international unit, IU, and so that's the standard strength of preparation for insulin. Heparin and penicillin are also prescribed in units. All right, but that's pretty rare. There's not a whole lot of drugs that are, but those are drugs that are. You'll learn that, and you'll rely upon it. Then we have some other drugs. One of them is potassium that is measured in milliequivalents, and so this is the strength of the ion concentration in the drug. Okay, so a milliequivalent is the number of grams of a solid contained in 1 milliliter of a solution. So electrolytes like potassium, we use those to measure, and it'll say 20 milliequivalents of potassium in a bag of fluid, right? And so that's the way that it'll read on there. And so that's sort of how you know what the dosage is. All right, so we talked about 6 elements of a prescription, but we're going to go through 7. So first of all, you're going to get, of course, you want the patient's name. You want the date the drug order was written, the name of the drug, of course, the drug dosage amount, the drug dosage frequently, the route, and the prescriber's signature. Okay, now that's not always necessary anymore because we have a lot of electronic processes throughout with drug prescription, right? But you're always going to need the patient's name. You're always going to need the date the order was written. You're going to need the drug, the dosage, and the frequency, and the route. All right, so within prescriptions, we have a few different types. Sort of like when you're ordering stocks, right? You have your standard written prescription, and this applies without a renewal date under the prescriber that writes the prescription, unless the prescriber alters that in some way. So the example would be give furosemide 20 milligrams IV push twice a day for 5 days, right? Within that, you can order an automatic stop date. So sometimes protocols in hospitals will use this to discontinue a medication after a certain length of time. We use it a lot with narcotics just because we don't want something to get forgotten and something continually goes longer than we intend. We also have stat orders. So stat orders, as you probably, if you've ever seen any medical show, means give it right away, right? Give it now. And it's only a one-time order. So when you say something stat, that's not a give it now and then keep giving it. It's give it now and then we'll wait and see and talk again, right? So give Valium 1 milligram, push IV now. Okay, so you're going to either get a single dose, for instance, just give me, 1 dose of Versed, 25 milligram IM for a surgery, right, for pre-medication. Or you're going to get standing prescriptions, which is sort of a set of circumstances to be applied routinely. So give nitroglycerin 0.4 milligrams sublingually every 3 to 5 minutes for chest pain, to a maximum of 3 doses in 15 minutes, right? Make sense? Okay, PRN prescriptions. So the PRN prescription is a nurse-based understanding. So when you say something is PRN, it requires the nurse to determine within the parameters that you've been given in collaboration with the patient, the physician, and it specifies the condition for when the medication will be given, okay? And so it'll say and it also has minimum time intervals in between doses. So it cannot be given more frequently than is prescribed. So you might see something say morphine sulfate 10 milligrams IM every 3 to 4 hours PRN for incisional pain. And so when it says PRN, what it means is every 3 to 4 hours the RN is permitted via order to assess and determine whether the drug should be given. Okay, and that's under your license. Doesn't relieve you of any responsibility if the decision is unsafe, but it says that a doctor has ordered this under your direct assessment. Okay, so we play a huge part in the safety of our patients. Maybe you've heard this but it's extremely common for patients to have medication errors in the hospital and otherwise. And we do a great job in a lot of ways, but there's still lots of it. And so we play a really great part in being able to protect our patients from having that fall through the cracks. So we're legally responsible for any medication that we give. Okay? So you have to understand that anytime you give a medication, you're responsible for looking up the medication and verifying everything from the spelling to the usage to the dosages, the routes, understanding what those things are if you don't know. And then you're going to ask another nurse provider to check the prescription and compare it to your resource data. So, you're always responsible for those things, but if you have some sort of an incorrect prescription, or even if just something doesn't seem right to you, you're going to initiate this process, okay? You're going to look it up in a reliable source. You're going to scrutinize it like crazy, right? Because you have your spidey senses are telling you there's a problem. And then you're going to have another nurse double check it to check their information and what they think. And in all those fails, you're going to contact the prescriber, tell them what you think, and work through with them for clarifications or changes or whatever needs to be made, okay? But you have to be the one to protect yourself if you think that that's a problem. Okay, so they say that this is a medication error is any preventable event that may cause or lead to inappropriate medication use or harm to a patient. This says that it occurs in nearly 5% of inpatients. I would bet that it's much higher than that. Like this says, recent studies of medical errors have estimated they've accounted for as many as 250,000 deaths, the third leading cause of death. And this is in, I don't know when that study was, but I recently read a study that said that 80% of patients that are admitted to the hospital at some point will experience some form of medical error in one way or another. Most common errors, confusion based on similar drug names, lack of knowledge about a drug, lack of information about the patient, faulty communication, equipment errors, calculation and measurement errors, fatigue, distraction. You'll see these things and they come up every time we talk about errors. There's a lot of commonalities. Communication is one of the most common. And then we have a lot of processes to identify things like similar drug names. We try to do things to keep things separate, and we'll go into those. So avoiding errors, we have 3 checks and 7 rights. Okay? These are system-wide measures that everyone uses to prevent errors at your institution. Critical thinking is important, right? And so you're always thinking to yourself, we're not robots, and so we don't just follow the orders. We follow the orders and we ask questions like, are we, or what if, and why. And you ask those questions because they catch problems. So it's very easy to make mistakes if you're not thinking outside the box and you're just doing what you're told. But humans make mistakes, so we have to be on the lookout for that. Are we following standardized protocols? They're there for a reason, because they help reduce mistakes. So I don't decide that I'm just going to go off the protocol because I don't feel like doing it or something like that. Now, what happens if you are using all these things and you still make a mistake, right? You're using your standardized protocol, you know what you're supposed to do, you do something and you make a mistake. What's going to happen? Are they they're going to charge you criminally and send you to jail? Although there have been rare occurrences and they're related to gross negligence, the answer is almost always no. Okay, the idea is that we try to, it's called just culture, we try to figure out how to make the system safer without placing blame unnecessarily. So the question is going to be asked, were you trained? Did you follow the process? And if the medication error or whatever was made, was it reckless? Was it not? And if the answer is no, and it was just a plain mistake, then most of the time the process is going to be doing a root cause analysis, retraining, and trying to make sure that you take advantage of this opportunity so that it never happens again. Okay? Okay, error preventing technology. So there's different things. We talked earlier about human factors of error. There's different things that we do to prevent errors from happening, because we know that humans are going to make an error at some point. So what we do is we do computerized prescriber order entry. So these are things that we don't handwrite prescriptions anymore. This also allows for greater visibility as far as different technologies. For instance, different clinics being able to share information. And we can standardize certain orders electronically, right? So make sure allergies are standardized. So these are all great tools. The barcode medication administration is great as a backup check for what we already do. It does not replace what we do, but it is a great guardrail for us to have. And so are smart pumps. So a lot of times what will happen is smart pumps will have technology that disallow certain common errors that they've identified. It will even store certain information in the pump. It won't allow you to program outside of certain dosage limits with each medication. So there's a lot of great stuff that they do to help us prevent that. Okay, limitations of technology, right? So prevention of medication errors is a bit of a challenge. So factors contributing to this, alert fatigue, rigid program, sorry, I think I have a little bit of an issue with that. Let's move on. I'll come back to this. So if an error occurs, and so I'm going to talk about what was on the last slide. So some of the things that can create errors, fatigue from the caregiver, some sort of communication error, including like an environment that doesn't allow for psychological safety to report those problems, systemic problems that aren't fixed, that put people in places to where it's difficult to do the right thing. So if an error occurs, what you do is you have a duty to do no harm, right? And so you assess, first of all, you assess what happened, right? You assess the patient's vital signs and their status and make sure that you understand where they are and whether they're safe or not. And then immediately you report the findings to your to the primary care provider or whoever is taking care of them at that point. Next thing that you do, and this is all while making sure that the patient is not unsupervised if necessary. And then the next thing you're going to do is reach out to your supervisor and start to document what is being done and make sure that you're troubleshooting what can be done together. Okay, so you're going to monitor for side effects, verify that you made a med error, and then start to identify what happened. Consult your charge nurse, document, of course, that's going to be really important, and complete the incident report according to your facility policy, and do not document in the patient chart that an incident report was filed. This is because an incident report is for quality improvement purposes only, and if you write that the incident report was filed, then it makes it discoverable in court, which takes away the hospital's ability to protect itself from lawsuits based on just trying to improve care. So you don't want to put that in the chart. You just describe what happened. Okay, so this is kind of interesting. So when you're doing your medication, you're going to measure your vitals, right? You're going to assess the patient's general condition. Is it appropriate for the medication? Evaluate the knowledge of the medication. Identify biological factors that affect the drug metabolism. So this is all the things that you're thinking about even before you decide to give the medication, right? And throughout your shift. While you're giving the medication, you're watching their mental status, their coordination, their ability to self-administer if they're swallowing or something like that, or if they're self-administering in a different way, making sure that they are able to do what you thought they would be able to do. And then after, you're watching for the results, the effectiveness of the drug, side effects, adverse reactions, or toxicity, okay? These are the things you're thinking during your assessment throughout the process. Okay, so here's our process, and what we do a lot is we talked about the NANDA nursing diagnosis, and so around medications, you'll have things like deficient knowledge base around this medication, risk for allergic reaction, ineffective health management if they are unable to understand or administer the situation, risk for poisoning if maybe they're on an overdose, risk for aspiration, constipation, diarrhea, deficit knowledge related to the lack of motivation to learn about medications if they're not, right? So remember, these are all things that you actually look up. We can't make these up, but these are the typical ones you might see. Okay, so your analysis, the risk for injury. So what happens is the patients, as they get older, they tend to, hopefully not this many medications, but they tend to get on more and more medications, right? We're really good at giving new medications. We're not super good at taking them away. So we call this polypharmacy. And the more medications a patient takes, the higher the risk of a drug interaction. That's why, number one, that's why it's important. Number two, there's things with medication errors as well, right? And so if they have two meds, they have a 6% chance of a drug interaction. 5 meds, there's a 50% chance. And if they're on 10 meds, there's a 100% chance that there's going to be some kind of drug interaction. That's not really talked about very much. So when we're in our planning stages in the nursing process, we're thinking about things like what's their knowledge of the medication and treatment regimen when we're looking at outcomes. What's their adherence? Are they compliant, or are they likely to be compliant? Do they have motivation around it? Is there a possibility for abuse? And then when we get to interventions, we're talking about things like what could happen with this that we need to think about. Are they on aspiration precautions? Do we need to be teaching them on this type of skill to give this medication? Do we need to be working on health education, or maybe there's discharge planning things to be thinking about, right? And then, of course, goal setting. All right, so you're teaching a patient on what to take when they're self-administering. First of all, they want to understand what they're taking. So why are you taking it? How long? What are the side effects? Whether you're taking it with or without food. Give them some tools like, keep a list of medications that has everything. Tell them why. You can bring it to your doctor's visit. Have it ready for an emergency room appointment. They've never been to the emergency room, right? Maybe they don't know. So those are all good pieces of advice as a consultant that you can help them with. Always tell them that it's always important to take their drugs as prescribed, right? So if you have your antibiotics, or if you have your use like a divided pill box, those are all things that you want to go through with them, right? If you're on antibiotics, you want to take them until they're gone. If you have trouble remembering when you're taking your medications, you can use a divided pill box that can help you remember what days are important, right? All of those things. The other thing they want to know is make sure you tell your doctor what's going on, your side effects, your adverse reactions, any questions. Mention to them, unless it's completely unlikely, that if they become pregnant, that means something. And so report that immediately to your provider. And then last, think about safety. So if you wear a medic alert bracelet, make sure that people know, that you wear one. That's why you wear it, right? Because you want to let somebody know if something's going on. Don't take meds prescribed for somebody else, right? The reason that they need to be prescribed for a physician is because there's an individualized review of your situation before it's ordered. So to give somebody else something that was assessed for you is obviously not safe. If it's necessary, how to use a child-proof cap. Most elderly adults cannot do well with that cap, so just make sure that they can open it. And then if there's any expired medications, how to expire those, how to get rid of those safely. And then we're going to talk about administering drugs correctly with them. So we teach them how to read the label. We teach them everything I'm teaching you now, right? We read the label. We use appropriate measuring tools, teaspoon, etc. Asked for help with opening medications if their hands are stiff. So that's sort of like taking them through troubleshooting what could happen. How to store drugs safely. So if you're going to store it, don't throw it into a container that doesn't have any label on it, right? Keep it in the container it came in. Store it in a dry place, away from sunlight and heat, out of the reach of children, right? Those types of things. The other thing, too, that's common and can get in the way of somebody taking their medications appropriately is if they are they ran out of supply. So what are the expiration dates? How much do you have left? And what's your system for making sure that you're telling your doctor soon enough? Okay, let's go through the 3 checks and the 7 rights. So the 3 checks, first of all, why, am I, and what if? So number 1, before you pour your mix and draw up the medication, check its label against the MAR, verify the name, route, dose, and time. And that should be a match, right? After you prepare the medication, before returning to the container on the medication cart, check the label against the MAR entry again. So you're not checking the label against the MAR. That's not suggested, right? The MAR is the source of truth. You're checking that with the label to verify that what you gave has just been verified, right? We don't check it with something that's written on the whiteboard. We check it with the source of proof. And then at the bedside, you check the medication again before actually administering it. Okay? So that should be 3 times that you're double checking it before it ever even reaches the patient. Then you have your 7 rights. So there's 6 written on here, and I'll give you your 7th. So the rights of medication start with the right patient, the right medication, of course, the right dose, the right route, the right time, the right documentation, and the right reason, right? And so I want to make sure it's the right person. We want to make sure it's the medication we intend on giving them. We want to make sure that it's the accurate dose so that it's safe. The route, we don't want to give it orally if it's supposed to be given a different way. We want to give it at the right time, so not 3 hours after it was supposed to be given, because that could change future medication interactions and things like that. The right documentation, which means we can't forget that we gave it and not document it, because that's going to lead to more errors down the line. And if we don't document it, it didn't happen, right? And then finally, the right reason. Am I giving it for the right reason, or is it inappropriate based on the order? And then the right to refuse, of course, too. Okay, so here's what is a MAR. You'll see something like this in your charting. And I think this is epic. So you have a patient, and what you're seeing here is their medication orders, okay? So this is the MAR. It tells you when it's due. It tells you the dose, okay? And then it actually gives you the order details. So you have your 1 capsule, and it's very detailed, 2 times daily, oral, 100 milligrams, and then it has recent actions, when it was last given. It has hold for loose stool. It has the generic and trade name. Trade, generic. Okay, so it has everything on here that you need, and that's what the medication administration record, the MAR, is supposed to have. Okay, so for your oral medications, the most common route of administration for meds is oral. Okay, in your basic nursing textbook, there's a procedure, and your text has all of this stuff in there. So review the oral medication process. We'll do this in class in our talk through, but check that out. And then you can do buccal or buccal sublingual medications. So you can either administer in the cheek, which is the buccal route, or sublingual is under the tongue. Those are both very vascular areas in the mucous membranes, and those can rapidly enter the bloodstream. So there's no water for these routes, and do not swallow. So you don't want to create a lower concentration by adding water in there, right? You want it to be directly in the mucous membranes, and you don't swallow it because you want it to be absorbed in that area. Okay, and here's what I was referring to. Topical medication. So these are applied directly, all right? They can be placed in body cavities by irrigation or instillation or suppository, but ultimately they're applied directly to a body site. So a local is something like even like zinc oxide ointment to protect the skin against irritation. So something you rub on your skin. Systemic could be absorbed through the skin and mucous membrane more like an estrogen patch, for instance. And then a transdermal, which allows for controlled amounts to be administered over time. So you might see like a nicotine patch, for instance, right? And they wear it for 24 hours because that dosage is continuing to be left on, which is why you don't want to add another transdermal patch without removing the previous one, correct? So whenever you're removing a transdermal patch, the one thing you should be, a few things you should be aware of. Don't do anything with the patch. Don't cut it. It's supposed to be, administered exactly as it's created. And also wear gloves when you're adding and removing it, because it's possible to get some of that topical cream or patch on your skin. So irrigations and installations. So we irrigate things and instill chemicals into situations where we remove or discharge a foreign body, right? So we irrigate and we debride a wound, and so we're washing out those things. We apply heat or cold to an area, for instance, to cool down the body or even to reduce swelling. We apply medications. We prepare an area for surgery, right? We do that to, maybe kind of, maybe we inflate a belly, or we wash with a solution, an antibacterial solution. In our eye medications, we use those for local effects to treat infections, glaucoma, even lubrication for people that have dry eye. We can irrigate it to remove foreign bodies, even secretions or harmful chemicals. So all of those things are things we use to help treat the eye. There's also other things that you might see with ophthalmologic medications, is that it will say on the bottle for ophthalmic use only. And the reason for that is because it's not intended for anywhere except the eye. Okay, it's created exactly for that reason only, and so you just want to be careful about that. And talking about the cornea real quick, it's a part of the sclera in front of the iris and pupil. It's easily damaged, so don't place medications directly on the eyeball. We put it in the eyelid and then allow it to come back up. We also don't put anything directly on the eye, like place it. We don't put the medication dripper on the eye, right? We drip it on top of the eye because you can scratch the cornea, you can do other things that can irritate the eye. Just like that, that's the way you want to do it. Okay, so otic medications, I never feel like I could say those right, but medications for the ear. These are dropped in the ear to treat internal, external infections. You can apply heat to the area to remove earwax, right? Those types of things. Even numbing medication. And what you do is you always want to pull that ear up and back. So not just straight back, not just straight up, but up and back. That most clearly opens the ear canal so that you can administer that easily. When you're using nasal medications, usually patients can self-administer this. It's most comfortable. And so if you're going to use something for a cold or a sinus infection, you're most likely going to use this type of medication. Patients are going to sniff or drip it themselves. Nasal decongestants are great because when you have swollen membranes and you can't breathe, that helps shrink those membranes and allow better airflow. There is such thing as a rebound effect, which essentially just means that you cannot use Afrin to keep your nasal airways open chronically, because what happens is your body just becomes dependent on it, and what will happen is if you don't have it constantly, then it will always be feel like it's clogged. And so you use it temporarily to clear those areas, and then you don't continually use it. All right, so here's a couple things that you want to know. So here's nasal medication. So this is kind of interesting, right? So when you do this and you spray it and you tilt your head back, it's all going into your stomach, right? So, but if you lean forward and you do it, it goes up into your sinuses and stays where we want it to. And then, when you sit up, it's at least absorbed. So that's something that just being reminded right now helps me remember that the next time I can do that. But I think we all might be surprised by this. And as we talked about, there's sinuses up here above your in your head, right? And so when you get when you have an upper respiratory infection or you get a sinus infection, what's clogging up are these little sinuses right here. And so that's why things like nasal saline washes are good for cleaning those out. But if you need to apply a medication, where you want it to get is inside these sinuses, right? And so that's what you're trying to get. Okay, vaginal medications. Those come in lots of different forms: jellies, liquids, douches, creams, tablets, suppositories. We use them for contraception. They can be used for bacteria, particularly before we do GYN surgery, right? You can decrease the bacterial load in there. It can reduce dryness. It can treat itching or infection, or even to induce labor. Douche is essentially an irrigation source, and it's not completely unlike an enema, except that it's used in a different area. But it's low pressure, and you administer an antimicrobial solution to remove anything that's in there that's irritating, and you can even apply heat or cold if you needed to through that process. It does disturb the normal pH, and so you can't just use it without a plan and use it indefinitely. So it disrupts the healthy balance of microorganisms in the vagina. So just be aware of that. Rectal medications. So rectal suppositories and liquid installations are used to help with bowel movement, and can also help with nausea. So for instance, if you have so rectal medications, they are absorbed better and may provide for higher blood levels, because the venous blood in the rectum doesn't pass through the liver. It goes directly back into the general circulation, which is another reason why you may have heard about, for instance, people inserting vodka in enemas and potentially dying, because that enters directly into the bloodstream, doesn't pass the liver, it just goes directly in. And so again, because of that difference in concentration and strength of the vodka going directly into the bloodstream, there's miscalculations that can occur, right? And so you want to be careful about that. And if it wasn't clear enough, I'm telling you, just don't do it at all, not just think about whether it's appropriate or not. Subcutaneous and IM injections. All right, so these are parenteral medications that we inject into the body tissues, and they're absorbed faster and more completely. And once they're given, of course, they cannot be retrieved, right? And the tissue damage can happen if you're not careful. So you just have to understand where you're injecting, why you're injecting, and what you have to be thinking about based on the medication. So do you have to move the medication around? Is the site that you've selected appropriate? Is the tool that you're using going to get to the correct layer, etc.? So here we have an intramuscular injection. Here's your 90 degree injection, and you'll see it goes all the way through the epidermis, the dermis, the subcutaneous tissue into the muscle. And the idea is to get it intramuscularly, right? So you're going to get inside there. The subcutaneous does the same thing, but you can inject it a couple of different ways, 90 degrees or 45 degrees. But the key being you get into the subcutaneous tissue. And then if you're going to do an intradermal, which is just essentially right here on the epidermis, you're getting that just below the skin, and you're going to go 15 degrees or lower there, so really low. Okay, so some equipment. Needles are made in various lengths and gauges. So if you're going to give an IM injection, you're going to need a longer needle. If you're going to give a very viscous medication, you need a larger gauge needle to get it through that area, right? So the gauge refers to the inner diameter of the needle lumen, and it goes from 14 to 30. So 14 would be a very large number, a very large diameter, okay? And then the 20 gauge or 30 gauge is a very small diameter, okay? And so you want to select that based on the patient size, skin condition, like I said, the viscosity of the medication, and the speed of the administration. So the great ones that are to use for subcutaneous are the 25 to 30s because they're very easy to insert. They don't cause a lot of trauma, and patients really like them. 14 to 18 gauge, those are tough. And so when you inject that in, that's going to hurt. So make sure you're doing it because you have to. So viscous medications are usually the only situation that requires the larger ones. Okay. So let's look at the anatomy of a syringe. So you have your plunger here that goes in and out. You have your barrel, and that pressure puts the medication into the patient, right? You have your tip and a hub. Usually these now are not, they're called lure locks. They don't just slip on and slip off. They have threaded, threads so that they don't separate accidentally. And then you have your gauge of needle here, and then your shaft, and then your bevel. So we talk about keeping the bevel up, right? So this is the bevel, the top end here. The sharp here, end here is the part that injects into the patient first, okay? So make sure that the sharp end of the knife goes in first, because if you try to do it the opposite way, it's not going to go in well and it's going to hurt. And it's also probably going to slash the area, and it's not going to be a pleasant situation. Okay, so needles, they go from all different sizes, from 3/8 to 3 inches. If a patient has a lot of adipose tissue or a lot of muscle, they might need a longer needle, right? But an IM usually, depending on where you're injecting, is 1 to 1.5 inches, and shorter needles are needed for intradermal or subcutaneous. There's also something called a filter needle and filter straws. Those are used to make sure that you don't have any glass in your syringe. And so, like you can see the ampule on the right there. That's an example of a drug that if you open that, you're going to want to use a filter so that there's no accidental shards in the medication that you pull into the syringe. And then you'll also see safety needles. You should see these throughout your training. These are just needles that are engineered so that sharps and injuries are more difficult, okay? Easier to prevent. Oh yeah, one thing about the filter needle, you can't use the filter needle to inject someone. So you have to remove it with the filter needle, and the filter needle is blunted. So you have to remove it and then replace with the needle that you're going to inject with. So we went through the anatomy of a syringe, and I talked about the lure slip and the lure lock. Your medications are all going to have a lure lock now. The lure slip, the downfall of that being that it can just slip right off, right? So, okay, when you are snapping off the top of an ampule, you can cut yourself. So What we do is we use gloves. We use devices that help us break this off. Some people will use an alcohol pad that is still in the package, and you wrap it around the top to protect yourself and break it off. And then you use a filtered needle to drop the medication, change to a regular needle, and then inject. The other vial below is just a typical single or multi-use plastic or glass container with a rubber stopper. The ampule is an open system, so you have to be careful about the sterility and everything, of course. And then the vial is a closed system. You still have to be careful about the sterility, but it requires air to be injected into there to withdraw the medication. So just remember that you have to push as much air in there as you're taking out. All right, so needle stick injuries and needle stick sharps containers. Always dispose of your needles, any glass, any other sharps in the red puncture-proof containers. They have a container opening in the top. It usually collapses down when you drop something in there. Never reach inside of it. Never force a needle into it if it's full. Just never leave a needle at the bedside or in the bed. Okay, so we go directly from injection to the sharps container, and we also know where that route's going to be and make sure it's clear before we do that. Okay, we always have that in our minds when we use a sharp. And the thing to know about the sharps container is it usually has to be changed around 3/4 of the way full. As you see here, there's a little bit of a line there that helps us remember. Okay, so a subcutaneous needle. So as we said, there's a layer of fat below the dermis. The absorption is fastest in sites in the abdomen and arms, slower on the thigh and upper buttocks. Okay, so just be aware of that. When you're using your site selection, inject 2 inches horizontally and vertically from the umbilicus. Okay, so you're going to stay away from the umbilical area, and you're going to rotate sites whenever possible because you don't want any scarring or hardening that can happen with constant injection. Okay, so you do rotate your sites. You're going to want a shorter needle, and the gauge is going to be very small. When you're administering heparin, which is also a subcutaneous injection, it's very fast acting. Well, it's most likely that it can be IV, but that's a very sensitive area. But we're talking about the subcutaneous. Heparin is always a drug that is very carefully administered. It interrupts blood clotting, and so if we have an overdose of that, then that prevents clot formation, right? And so that's obviously something we want to have a careful watch on. But it can be used to prevent clots and with MI and stroke. So it's a great drug. It's just something that we have to use very carefully. And then there are some times when we're going to use IM injections, right? Intramuscular. So this is absorbed faster because of the rich blood supply in the muscles. The large muscles is what we use. The vastus lateralis, which is the outer aspect of the quadricep. The ventrogluteal, which is the upper aspect of the gluteus on the outside. And then you can use the deltoid, which can tolerate up to 1 milliliter. Now, when are you going to not use an IM injection? If you have more than about 5 milliliters of fluid, and that's even a lot, there's something wrong with the order if it says that you're going to inject that much, okay? So that much would need to be considered for IV, or maybe there's an error in the order. So when you're looking for a site, you want something that is away from nerves, blood vessels, and bones, free from injury. So this safe from nerves, blood vessels, and bones, we do that by classifying certain sites, right? Which is why we tell you the vastus lateralis is a good one, the ventrogluteal is a good one, the deltoid. Those are all good distances from those things. The patient has to be free from injury, right? We don't want to inject it into an area that has a major problem, abscesses or necrosis or any kind of other cuts or abrasions or anything else that's happening. And then it has to be large enough to accommodate the volume of the medication. So you have your iliac crest here, right? And you have your greater trochanter. And so right above that is going to be where you're going to be able to inject right in that green spot there. And then on the deltoid, right in the middle. Okay, you have your acromion process, 2 fingers down and anything below that. There you go. Okay, the Z-track method. So the Z-track method is important. What it does is you essentially pull traction on the skin so that the injection, when you puncture through the skin into the muscle, the medication is injected, and then when you remove the needle and you let the skin go, the traction moves back over the hole that you just punctured. And so it makes it more difficult for the medication to return. So it traps the drug in the muscle, okay? And so what you do is you pull traction on the skin, you pull it tight, you inject, and also, by the way, it makes the injection more tolerable if you pull it. You don't want to pull it so far that it's going to create a problem with getting to the area, but as soon as you inject, and then you remove the injection first, and then you let go of the skin afterwards, and the skin slides back. Okay, so older adults, you do have to consider the fact that anyone over 65 is more likely to have an adverse effect and toxicity. And so we have a lot of people that are just getting older everywhere, and more people that are taking prescription medications and more use of over-the-counter drugs. So it's just really important to understand that older adults, even with or without chronic illness, can be pretty seriously affected by this and are hospitalized all the time for adverse events. So sensitivities that can be caused by this. So prescribers talk about start low and go slow. So low dose and then slowly adjust up to time. That's the best way to make sure the patient minimizes the side effects and also gets the most appropriate coverage for the drug as they get to where they need to be. Things like body weight or organ functioning, drug molecule receptors, they're more older folks are more susceptible to CNS depressants. So it's really important to monitor their labs, especially their liver and kidney function, to make sure that all that stuff you're giving them is being excreted properly and metabolized. Okay, so just be aware of all these things in any older adult, that there's always a risk for that. So here's the physiologic changes of older adults. So we already know that they have a reduced cardiac output, which reduces their absorption and distribution, right? Because they're just not as effective as pumping blood as they used to be. Their blood flow is not as good as it used to be, which again affects the absorption and distribution. Their GI pH is increased, which alters absorption. Their peristalsis decreases, which delays gastric emptying. Their hepatic system, their enzyme production is lower, and their blood flow is lower, which means a lower metabolism. And then their renal system, their blood flow is lower, their functioning, their GFR, and their function of the kidney is lower, which means lower excretion. Okay, so I hope you've enjoyed this. You guys all did a great job, and I think we're all going to do a wonderful job this semester. And I look forward to speaking with you again.